Welcome to this tool and techniques session. We are discussing today a new horizon in IVUS-guided PCI of calcified stenosis with artificial intelligence. What are our objectives? To learn about the new AI-assisted IVUS image interpretation, to share experience on an algorithmic approach through an IVUS 1-2-3 workflow when dealing with heavily calcified lesions, and to tailor treatment through the choice of the most suitable drug-eluting device to the given anatomical setting. What's in the box? Not in the lunch box, the ones you have on your knees. What's in this box? A recorded case by the team in St. George's Hospital, London, UK. By the way, we should have the operators somewhere in the room. Let me identify them, where the operators are. And where is the chief operator? He did not join yet? Okay. So you will be our victims today. We'll have 2 focused lectures on key topics and an outstanding faculty standing right and left next to me. Who are we? My name is Emanuele Barbato, anchor person from Rome, Italy, and I have the privilege to co-chair this session with Nieves Gonzalo, who does an introduction, our EuroPCR course co-director. Outstanding faculty, as I said, from the right to left, Dejan Milazinovic, Roberto Diletti, Vani Mahadevan, and Robert Byrne. 2 operators, very good operators, James Pratt and Ganev Mautra, from St. George's Hospital in London. This is an interactive session, and Nieves is going to explain us how to interact. There are no slides here.
Oh yeah, I have don't need the microphone, I'm here. So thank you very much for attending this session, and please, you know that in all sessions at EuroPCR, your interaction, your comments, questions are an essential part of the session. So you can interact through the app, and of course there are also microphones on the room, so please stand up and go to the microphone or make your questions through the app, and I will be checking them and bringing them to the attention of Emanuele.
Excellent. Why don't we start, Vani, with the first lecture. Guide us through the innovations in IVUS-guided PCI.
Great. Thank you very much, Emanuele. It's a real privilege to be here. Thanks to Boston, to PCR, to my unit for supporting me, and to a great faculty. So our objectives are to briefly look at why we should utilize IVUS in complex and calcified lesions, briefly touch on what the reported barriers to use are, and look at how systematic workflows and AI can help us to optimize our interventional procedures. So very briefly, this is slightly crowded, but just to take you through a timeline summary of randomized data, the initial data for IVUS didn't really show a benefit of the use of intravascular ultrasound from home, DES, IVUS, and reset, but this was short lesions. We then had AVIO and AIR-CTO that looked at more complex lesions, and there was some benefit in the soft endpoints of minimal lumen diameter and late lumen loss, but no benefit in hard endpoints. But then between 2015 and 2023, so early 2023, when Renovate Complex actually published, there was a whole plethora of data demonstrating a significant difference in the hard endpoints that we look for in cardiovascular trials, such as mortality, MI, and reduction in target lesion revasc and target vessel failure. And there's ongoing trials with optimal left main, Dynami for iSTEMI, IVUS CHIP and IMPROVE still recruiting, and IVUS ACS, which published in the Lancet 4 weeks or so ago, demonstrating a benefit in the use of IVUS in ACS patients. So why use IVUS in calcific coronary disease? Well, because calcium is a real problem and we're struggling it with older and more comorbid patients. This is a study, or this is data actually from 7 pooled studies showing that if you had severe calcium in a lesion, you were twice as likely to have a cumulative incidence of death or MI. This was translated into left main PCI, so the XL calcium sub-study that looked at IVUS in left main also looked at calcium and showed that the 3-year mortality rate if you had moderate to severe calcium in the left main was almost double. So again, calcium is not nice. And then Renovate Complex, of course, looking at over 1,600 patients in complex lesions that you see listed on the side, showed that there was a significant increase in the cumulative incidence of target vessel failure with the use of angiography alone. So imaging reduced that endpoint significantly, p-value of 0.008. But what's really important is that the incremental benefit was gained when we used imaging and we optimized our stent procedures. So it's not just taking the catheter, it's actually doing a procedure that gives you optimal stent outcomes. And that's through looking at your lumen areas, and we'll go through that with the IVUS 123. What are the barriers to use of intravascular imaging? Well, Professor Burns on the panel and has very kindly pointed me towards his publication, but this is across Europe and global. The core factors that came out were high cost, prolongation of the procedure in the cath lab, regulatory issues such as reimbursement and lack of training. And we actually ran a survey that was led out of Portsmouth, my unit, but with collaboration across the UK and with the UK National Society. And these were the core barriers, again, very similar to what Professor Burns' publication showed, which is increased procedural time and reduced lab turnover. So we asked physicians, and we had about 30% of clinicians in the UK respond. Red bars are agree, so over 60% or around 60% agreed that procedural time was an issue. Lack of education and training was an issue. Lack of support and proctorship once you become an attending or a consultant was an issue. And the high upfront cost of the catheter. We also looked at physician challenges around interpreting imaging by imaging etiology, and we found that if you did have formal training and fellowship, which is the green bar, you felt much more confident in interpreting etiologies than if you didn't have training, which is the blue bar, and these were statistically significant. And around 15 to 25% of operators who were confident in use of IVUS and 25 to 40% of operators who were confident in the use of, not confident, in the use of IVUS were still not happy interpreting some of the basic things such as under-expansion, malapposition, and edge dissections. So quite important factors. So how do algorithms help us? Well, they help to streamline education and training through competency and consistency. So this is a case that I did in my unit. I'm going to have to click on them to get them to play. So this was a calcified LAD with disease extending to the left main. Ended up not able to cross, so took a 1.5 rotor, modified the vessel. And then we used an IVUS 123 approach to establish the lesion length, which was around 78 millimeters, looking for landing zones with less than 50% plaque burden, assessing the plaque morphology, and you can see here lots of rotor reverberation where the rotor burr has contacted nodular calcium and fractured it. And then we're looking at vessel sizes so that we pick the right size stent and we appropriately optimize it. There was some focal wasting with a non-compliant, so I took a 3.5 Wolverine, which was then up nicely, as you see on the right-hand image, took that into the left main as well, and this is the final angiographic result. So then when we look at our post-stent workflow, we're checking for geographic miss and edge dissection. So these were my proximal and distal edges, proximal on the right of your screen, distal towards the left of your screen, and there's no edge dissections there, and they're landed in pretty good, healthy vessel. We then look at apposition and expansion, and you see here in the center picture of the three at the top, there is quite eccentric stent expansion around nodular calcium, but the areas are very good, so you wouldn't chase this because there's a risk of perforation. So a systematic approach to looking at your areas and how well optimized your stent is. And that's what the algorithm helps us to do. And how can AI help us? Well, we said that operators from surveys felt that education and training was an issue and they had challenges with interpretation. So actually, this is where AI can really help. And this is a study done by Gary Mintz and Akiko Mehera's group looking at the correlation of deep learning, so machine learning versus expert IVUS operators, and there was a very strong correlation between how they predicted lumen areas and lumen diameters, which you see in the graph that's on the slide. There was also an extremely good correlation and agreement between machine learning and human experts for vessel and lumen areas and diameters and final stent area measurements and choosing balloons. So AI really advantageous in that it can help us when we're not confident to know how to manage lesions and how to know whether we've optimized our stent. So helps to support physicians in image interpretation and generates procedural optimization and safety. So finally, this is the last slide. This is the newer Vigo Plus system, which gives automated lumen areas based on machine learning. It does have an 8mm pullback speed, so a 62% reduction in procedural workflow time, which will increase efficiency through the cath lab and takes away the barrier of people not using it because they're worried it's going to slow the lab down. And in summary, workflows and AI can help to break barriers by facilitating consistency in education and training, cath lab efficiency, and allowing optimization of procedural and patient outcomes. Thank you very much for listening.
I think we are ready to go to London and see the case they selected for us.
My name is Gao Hong. I'm one of the Interventional Cardiology Fellows at St. George's Hospital in London. I'm here to introduce our recorded live case. The case was performed by Professor James Spratt and Dr. Ganeeth Malhotra. Our case is an 80-year-old man who presents with syncope and angina. He is physically active and still works as an electrical engineer. His history includes coronary artery disease, for which he had 2 coronary artery bypass grafting in the past. He also has atrial fibrillation, for which he takes apixaban, and type 2 diabetes, for which he takes metformin. His patients are listed on the right. His blood tests were largely unremarkable. A transthoracic echocardiogram showed mildly impaired left ventricular systolic function with moderate aortic stenosis. He also had a pacemaker implant, as the syncope was thought to be related to AF with periods of AV block. He then had a CT coronary angiogram to investigate his angina. The coronary angiogram showed severe native 3-vessel disease with a CTO of his LAD and right coronary artery. His lima to LAD was patent, but his vein graft to his LAD is now occluded. His vein graft to his OM was also found to be occluded, and his vein graft to right coronary artery was found to have severe stenosis. As seen on his CT, his native right coronary artery is occluded. The vein graft to his right coronary artery had a long segment of severe disease in the mid-body of the graft. His native left coronary artery showed an occluded LAD at the ostium, with a segment of disease in the proximal left circumflex artery and a critical stenosis at the ostium of the OM, as well as severe disease in the mid-OM. His lima to LAD is patent, and his vein graft to his OM is occluded. He subsequently underwent successful PCI to the vein graft that supplies his right coronary artery. So the target for intervention today is his native left main coronary artery into his OM. We were able to use his CT that was done beforehand to plan his procedure. Here you can see extensive calcification involving all of his coronary arteries. Flex artery in particular had areas of concentric and eccentric calcium that would require modification during his PCI. To correlate or co-register the calcium seen on his CT onto his angiogram. So the target for intervention today is the native left main coronary artery into the OM, and with that I pass you on to the operators. Thank you for your attention.
Great. So we've seen the current case, our case that we have to discuss together and help our colleagues in treating this patient. 80 years old, post-CABG, heavily calcified circumflex coronary artery with a tight lesion on the marginal branch. So in addition, we have this bonus of the coronary CT available that is already anticipating some additional challenges. Let me start here around the table, trying to understand if this was the patient on your cath lab table, how would you start thinking, treating this patient? Shall we start from Dayan to the right side?
Yes. I think having the knowledge of the CT up front would help in this case, or did help in this case, acknowledging that it's a lot of calcified plaque present. So you would start thinking about the potentially plaque modification before you even get to the cath lab, which I think is important. Once you start planning the procedure, the first next step will be, after I pass the wire, what is going to be the next device? And I think that is going to be the major discussion. So based on what I've seen, I may anticipate that it will be very difficult to pass anything through this lesion. And when we have the situation that we anticipate that any device will be difficult to cross, then of course atherectomy, patient atherectomy is something which would come into my mind as the first next step.
Hold on. Robert, what are the anticipated challenges here? When you see this case, you hear this discussion, what are the first challenges that come into your mind, and what are the measures you would put into place to overcome them?
I mean, I think in our centre we wouldn't use as much CT in advance. As Dejan said, we have the information from CT here, but for me there's three things we do. We want to define the extent of the calcification, we want to modify the calcium, and then we want to check that we've modified the calcium. So this is the way I think about it. In defining the calcification, I think what we really need is intravascular imaging. So the crucial piece of information is, can we get good IVUS imaging of this vessel, because that will dictate my calcium modification strategy. And if we can't, if it's imaging catheter uncrossable, then we'll be thinking about upfront atherectomy.
That's a good point. Let me try to pitch our colleagues in the room here. We've seen that CT was available in St. George for this patient. This is an 80-year-old patient. Is it your practice as well to do coronary CT in this patient? If yes, please raise your hand if you would do CT before entering this patient into the cath lab. So 1, 2, 3 colleagues, 4 colleagues. So it means most of the colleagues in the room would have your same practice. In a way, CT would not be available, and we need some additional information. How about intravascular imaging, Roberto, here? It's a tight lesion. Are you confident that we would be able to acquire these informations even before modifying a little bit this plaque?
It's a heavy calcified vessel and is a little bit tortuous. So I am confident that with a high chance we will not be able to cross with imaging. But it is correct. Imaging is giving us crucial information to decide our strategy. The problem for me is that there will be a real challenge to cross. Most probably they will not be able to cross, and then you are obliged to go for atherectomy. You have to prepare the lesion up front because you have a clear indication that you cannot cross.
So let me hear from Vani and Nieves, both of you experienced operators. We heard that we are not that confident that we would be able to cross. Well, first Nieves and then Vani, your tips how to manage this?
I think that there are 2 additional problems in this patient that makes it probably even more difficult. One is a post-CABG patient. So this is, we know that comes with even more calcium, and then it's a circ. So it's, I would say the worst combination is circ in a post-CABG patient. So
totally agree.
Tough.
Funny. Yeah, very much the same. They say you should never give your friend a circumflex to do in a live case, but the angulation here is, remarkable. So I think even if you were to get a wire down and across, delivery of a microcatheter and all of those kind of things is going to be challenging, and you're then looking at thinking up front about how do I take that angulation off, and then use of things like guide extensions come into mind. So I agree with Nieves, and also post-CABG patients always have more calcium than you think they're going to have, just because of the upstream rapid progression of calcium once the grafts are on.
So we heard more or less some of the points. Let's move a step forward. Let's start to anticipate some procedural setting. What is the preference in the room first? For transradial approach here, would you do this patient transradially? Raise your hand. Do you think you need larger bore, larger guiding catheter? Would you think you would need a femoral approach? Raise hands. Minority would do this transfemorally. That's good. Anything else we missed from the discussion here? I think we touched more or less all the points. Yeah? So why don't we have a look what they did in London?
Pretty tight, yeah?
Yeah, good test for this thing. Suggested minimal calcium.
It looks minimal, doesn't it?
Yeah.
Okay, just back to AP caudal, please. Maybe not too low. No, that's
Pretty
okay.
good. Ooh.
Let's swab, please.
Let's just open a trapper balloon for later, please.
Where's that going? More funny.
A test?
Yeah. Oh, no, I think it's... No, it's...
Well, it's a
more
little
funny.
thing.
See if it will go the other way, though. No, I think we'll take that.
That's
the
right.
graft, is it?
Yeah.
Perfect. We'll leave that up
Brilliant.
there. And it's visually arrest.
It's going down to 138, 115, 115. If you don't do that angle, crossability.
I can hear what you're
If you
saying.
don't do that angle, then crossability of that with... Oh, that angle. That's good.
We get a little bit of deceleration at the top, don't we? But
Yeah, the left main, isn't it?
yeah, left me
right.
more than
2 secs.
you go off.
Trapper. Thanks.
We may as well just do from there.
Yep.
Go on.
It's 12.
Oh. Fine. Yeah.
12.
Think of it as an investment, sir. Okay. Down. Down.
Last time.
All right. That's where I got stuck before, so it's all okay. Passed up. Still that same area. It's the bend there. Again. Okay.
Just try and...
Centered that IVUS. It's a resheathed, yeah.
Yeah. Just do morphine first, then we'll decide later with the thing. Okay.
It's kind of pre-bifurcation, isn't it? And even proximal as well. All right, okay. So we can see why the guide extension is not going on anyway, but we haven't really dealt with that proximal lesion.
Yeah.
Thank you, Lassie.
I think you want to take it back a bit further than that, even, don't you? That's the aorta. Okay, fine. All right, very good. So then
Just
saying
click
it's
that little symbol. There you go. Yeah.
Okay.
It's 4.5
So
there.
I think kind of there we want to.
The first one, obviously, you haven't seen on the screen because in the interest of time, it was trimmed down by the colleagues, is that the IVUS catheter did not manage to cross. They tried, but it did not manage to cross. So with this, there is an additional challenge. We have seen that the workhorse wire was into this marginal branch. Not even the microcatheter could make it to go distal. And this is not an uncommon situation, right? So I would like to hear around the table, what are your tricks to get at least the rotor wire down, when not even the microcatheter can cross? Roberto?
So first of all, you have several tips and tricks. You can increase the support of your guiding catheter with an extension guiding catheter. The microcatheter is a good tip to let your wire cross. What you can do is to advance your microcatheter up to the lesion, really up to the lesion, and then it's giving a lot of more support to your wire to cross, the rotor wire to cross. Another thing that we have seen in this case is that they advance the wire in the venous graft, and this is also a trick to increase your support, because actually you can go quite far in the venous graft and you really have good support in that case.
Next question here I have is, how do we estimate the bar size? You might have your own protocol. We didn't manage to do IVUS here. IVUS could have been helped to select bar size. What is your recipe? Perhaps Robert, what is the bar size to start with in this case?
I think we tend to size with a burr to vessel ratio of 0.5 to 0.6. I mean, I know it varies depending on which guidance you look at, but these are the ballparks that we use, and we should apply to this case as well.
And beyond that, I'd like really you to share your techniques with a colleague, how to perform rotablation in this calcified tortuous vessel. It's a circumflex. How to prevent complication. We know that if there is a setting where we might have bar stalling, that's exactly where we can have issue. But with a little bit of technique, this can be prevented. I don't know if Dayan can comment on this.
So I think to the point about how large would the burr be, I would not undersize it. So I would not go with 1.25 because I think then there would be a larger risk of entrapment in this kind of anatomy. So I tend to take 1.5 millimeters for almost all of my cases, to be honest. So that would be the start for that one as well. Then there is another tip which I think is interesting in this respect, because what was giving the trouble here also was the tortuosity. So what one can do at the beginning is pass the wire, which is a bit stiffer. Over that wire, sometimes the microcatheter could go with a bit of luck, of course, over that tortuosity, and then you can place the rotor wire through that microcatheter, get it out, and then go with the burr. And I would keep the usual 160 is what we usually do in terms of rotations per minute. And of course, you have to be very careful here, because if there is a deceleration, I would of course stop and retrieve before going further. Being too aggressive in this kind of anatomy, I think would lead to an entrapment.
Now, a question to the colleagues, and then I will revert back to the panelists. Single bar or multiple bars? What would be your preference? Again, in the room, who goes for single bar rotablation here? Raise hands. Who's rather more prone to do multiple bars, so upsizing the bar size on the way of going? Very few colleagues. Now, if it is single bar, what would be the bar size to start with? Don't listen to Dayan, what is suggested. So who among you would start with 125 millimeter bar? Raise hands. Don't be shy. I'm sure there will be more. Okay. Who would start with 1.5 millimeter bar? Raise hands. Majority.
Thank you.
They did it for you.
And who would go for 175 millimeter bar? Anyone? Nope. Okay. Last point I would like to discuss with Vani specifically the extent of plaque modification achieved after the 1.5 millimeter bar and plaque modification. We saw an IVUS run, en passant, comme on dit ici. So can you analyze for us this IVUS run, please?
Sure. So if our tech team could switch over to the live player, please. It should come up on a split screen for the audience shortly.
There we go. We have it.
Perfect. Thank you very much. So they've going from distal to proximal, so this is the distal vessel, this is distal OM, and you can see it's quite a small caliber vessel. It's about 2.25, 2.5. And we come up through the vessel, and you'll start to see a bit more normal segment of vessel here. So this is a good distal landing zone, you would think, if you're not going to take lots of stent and small stent. You come up through here, and you'll start to see now some modification. So where you get some fractures and what we call here reverberation. So this is rotor reverberation. So just this part here where you've got wire bias, which is favorable because your IVUS catheter is actually towards the area of the calcium and where the nodule is, probably behind this. And so you're more likely to make contact with the calcium here. Here, the burr has made contact, so you see this reverberation artifact, which is effectively where the ultrasound waves are now able to escape past the calcium, and so you get this artifactual appearance. So when you see that after rotablation, you know that the rotablation's had some form of effect. Here, again, you see some reverberation up here, but you'll see some calcium fracture sort of at 7 o'clock, some disruption around 2 o'clock. And again here, you can see reverberation and fracture between 11 and 2. And as we come up through the proximal circumflex, you see the vessel caliber increases significantly. Here again, you've got an IVUS catheter that's now biased towards the side of the vessel, and you've got reverberation coming outwards here. So wherever the IVUS catheter is biased on the wire, that's where the rotor burr would have been biased on that wire, and you see the rotor artifact. And then as you come back from proximal circ into left main, you see down here at 6 o'clock a nodule of calcium. What's important to note is that the wire is biased away from that, so your rotor burr would have had absolutely no effect down here, but it's actually quite a large lumen. So that's sort of the effect of rotablation. So I think you could probably say that the rotor's had an impact throughout the burred part of the vessel.
Thank you very much. Very clear. Perhaps we are ready to listen to Robert on the latest on plaque modification. Time for you.
So thanks very much, and dear colleagues, a pleasure to have an opportunity to present to you briefly over the next kind of 5-7 minutes a roadmap for a systematic approach to calcium modification. These are my disclosures. Brief word of introduction. Look, I want to show you a new algorithm, the Cyclops algorithm for calcium modification, review briefly the treatment modalities, and a word or two on current or future evidence. The reason we're here is the growing need to treat calcium. We know this is due to the constellation of risk factors, the age of the population, but also on the positive side, we have an increasing armamentarium of devices with which to prepare calcium. The Cyclops algorithm, which I'm going to show you now, recognizes the fact that there are many algorithms out there for calcium modification, but we wanted to try to generate a streamlined, simple, imaging-based algorithm for guiding calcium modification. And it's based on 3 steps, which are define, modify, and confirm, tying together some of the things we've already discussed today. So if we start with define, I think the factors that we want to do, of course, we'll need to cross with a coronary guide wire. Hopefully we'll be able to pass an imaging catheter. If we can't pass an imaging catheter and pre-dilatation doesn't help us, then we'll have to use rotational atherectomy up front. But if we can pass our imaging catheter, which we will in the majority of cases, we're looking for circumferential calcium, defining the arc, looking at whether or not it's long segment calcification, checking the reference vessel diameter. Is it a large or a small vessel? What's the wire bias like? Is it biasing towards the calcium, particularly if it's nodular? Is there nodular calcification? And are there any reverberations at baseline before calcium modification? I think we know very well the benefits of intravascular imaging in calcific CID. Otherwise, I think we're treating in the dark. It improves safety, it enhances efficacy, and it optimizes durability of results. So our algorithm is imaging based. So we've talked about defining calcium, circumferential, long segment, vessel sizing, wire bias, nodular calcification, and reverberation. We then move on to modify calcium. And this is a three-step approach to calcium modification. We believe strongly that in most cases you should start with a one-to-one high-pressure non-compliant balloon angioplasty, possibly with cutting balloon angioplasty applied to high pressure. This may resolve the calcium issue in a large proportion of the cases. However, if there's residual constraint of the balloon at highest pressure, then we consider two additional supplementary strategies. These are rotational atherectomy and intravascular lithotripsy. Rotational atherectomy, we said again, 0.5 burr size. The ideal calcium characteristics will be balloon uncrossable lesions, concentric or eccentric lesions with a relatively small MLD, long segment calcification, or nodular calcification. Factors where you might want to consider intravascular lithotripsy at an early stage sized at a balloon size of 1.0 to mean reference vessel diameter is concentric calcium, especially if large, MLD, and also you may consider it in nodular calcium. This is something we can discuss if there's unfavorable wire bias. A key element is using cutting balloon angioplasty early in the algorithmic approach, either at nominal pressure or with high pressure. We know from studies such as Prepare Calc that a modified balloon strategy as compared with systematic rotational atherectomy in all cases can provide comparable results when you look at efficacy. And for our efficiency cath lab workflow, we factor in cutting balloon angioplasty up front. I mentioned either nominal pressure or high pressure. There is some evidence from the COP study suggesting that cutting balloon angioplasty applied at high pressure can result in a better degree of lesion preparation and calcium modification as compared with standard approaches. So increasingly we're using cutting balloon angioplasty to high pressure. In the interest of time, I won't go into the details of rotational atherectomy, but it's something that contemporary approach we're familiar with. Back to basics in terms of preparing your device. 160,000 revs per minute is what we aim for, paying close attention to decelerations as you would in a case like this. Intravascular lithotripsy, most of us will be familiar with it from our cath labs. We have second generation devices now available, one-to-one sizing, delivering up to 120 pulses, and certainly a useful part of the interventional armamentarium. Finally then, move on to confirm. You're looking particularly for signs of calcium modification. We've seen it in the case today, either in the form of increased reverberations or calcium fractures. If you're happy with the degree of calcium modification, then you proceed to stent insertion and optimization using the IVUS 123 stent sizing algorithm. Otherwise, you go back to the modify part of the algorithm. There's some criteria for IVUS optimal stent expansion that I won't go into here in the interests of time. The findings we're looking for in IVUS, to recapitulate then, are calcium fractures with clear disruptions in the calcium, or an increase in reverberations compared to the baseline reverberations that were present. We would like to test this algorithm in the Cyclops study, which will begin over the course of the coming months. 500 patients with severe calcification planned for PCI at 25 sites in EU, UK and Switzerland. And the aim of the study is to validate this streamlined intravascular imaging-based calcium modification algorithm for the treatment of severely calcified disease. Minimum stent area at the end of the index procedure and the clinical endpoint of MACE at 1 year are the outcome measures that we're looking at. Thank you very much.
Thank you very much, Rob. Let's reconnect. So colleagues did rotablation 1.5 millimeter, some degree of plaque modification, confirmed by IVUS. Let's see.
5.
Next steps.
Yeah, sure. I wasn't planning to go down that far down.
Yeah.
So again, there's a bit of eccentric I accept that's in the lesion, but we have that distal information there. What we're looking for is the bifurcation.
Yeah.
Better?
Quite a bit better, I think. Huh?
Better, yeah.
What do we think?
I think so.
I agree.
2.5 NC, do the distal, and then think about whether we're ready for implants.
Yeah.
Agree?
Agree.
Or further modification required?
Let's have a look at the lesions.
So this bit where it was really tight before, certainly it's
2515 or 20 NC, please.
with quite a lot of reverberation around here and here.
Yeah, is that the proximal lesion?
Yeah, that's a proximal lesion.
So I guess what we're looking at then is degree of recoil, isn't it? That the balloon was up, fully expanded, and your implants required to prevent the recoil. That's fracture.
What length is this? 15.
Bifurcation, I guess, that's completely fractured, isn't it? You can
just grab the wire.
Yeah.
Oh.
Yeah, so this would be the bifurcation.
It's proximal to that one.
Yep.
Yeah, so here. I don't know how well we're getting that really with it looks very eccentric again. Just on a bit further.
Beauty.
Yeah, so
okay, so
didn't say anything when it's perfect like that.
That was a bit better, yeah. A more straightforward case. Yeah, that's about right, isn't it?
Okay, just to recap the steps they went through, because again, in the editing, some messages could not easily come across. So they did further plaque modification with balloon dilatation. At a certain point, they decided to do IVL with a 2.5 millimeter balloon because they saw some degree of eccentricity, especially with balloon inflation. But Vani also mentioned about this during the first lecture of the IVUS, and they did final IVUS assessment. Intermediate IVUS assessment, because we need to decide whether we are happy with the current extent of plaque modification or we need to do more, or can we stent. First, let me check if there are questions in the chat box for the time being, Nieves, to be addressed. Okay, they were addressed already during our discussion. What is your guess? Are we done with plaque modification now? Are we ready to stent, Dayan?
So that's the big question. I mean, can we decide whether the plaque modification was enough based on imaging or based on the fact that an NC balloon sized to the same size that the stent will be fully expands in several projections? I think that's the main question for discussion. So what I do, I try to do both. I try to get the information from the imaging to see the fractures. That's an important piece of information. However, before proceeding with a stent implantation, I tend to like to take a same-sized NC balloon, inflate it, and then go to at least 2 different projections. If it's available, of course, rotational angiography, so that you can see it from different. Why is that? Because you can see an underexpanded area of that balloon from another projection, for example. Once that's done, I would tend to think that the plaque modification is good enough and would proceed with stenting.
Any additional comment from this side?
No, I would have the same considerations. I think assimilation of the information from intravascular imaging. Have you seen signs of calcium modification? Here we have. Is there evidence of fracture or increased reverberations? And then, of course, the common sense is to assimilate it with information from the balloon expansion, as the operators alluded to in their comments, where they said, listen, we think we've got good balloon expansion. We didn't know if they checked in a second projection, which we would routinely do. And then I think in that situation, you would proceed to size your stent and implant.
There was one technique James and Ganef have done during the procedure. I don't know if you know this inchworm technique.
Yeah, I like that.
Yeah. Can you explain us really
quickly.
In simple words, how it works and how it can help in this situation.
Yeah, I like that very much. I mean, the truth is, this happens actually often, at least in my practice. You prepare the lesions, you modify the plaque, then you try to go with the stent, and the stent doesn't want to cross, whether it's too long. The explanation, I think, very often is that there are some bits and pieces of calcium still protruding into the lumen, as we could see on the IVUS, actually. And then you catch it within an unexpanded stent, of course. You catch it along the way, and you cannot go down. So the solution to that, and I think it was nicely demonstrated here, is to go, of course, with the guide extension catheter over there, and then you can pass a stent through that. If the guide extension catheter doesn't go, then you use this inchworm technique where you inflate the balloon and you put the guide extension catheter just proximally to it. As the balloon is deflating, you get with the guide extension catheter over that balloon. And that really helps. I mean, I really use it. And I think from my humble experience, it has been so far safe. So you go over the deflating balloon with the guide extension catheter, so you win your way over to the place where you want to be, and then you go with the stent smoothly through the guide extension catheter.
Yep. I mean, I think it might have been a pertinent consideration here because you'll see they use the liquid guide catheter extension, which most people may not have in their cath labs, which we did clinical investigation with. It's a little bit stiffer. It's a circumflex. It's a little bit more challenging to deliver. And maybe that was why they used the inchworm.
How far we are in our IVUS 1, 2, 3 algorithm, Vani, in terms of IVUS assessment of the plaque modification? Are we ready to assess the stent size and length? I think you can analyze it for us. Thank you.
If we could go to the IVUS live viewer again, please, tech team. Thank you. So this is actually their third pullback, but it's the most relevant pullback in terms of looking at landing zones. So if I go distally, you'll see here that this is the small OM. As you come up through, there's actually quite a nice landing zone here. And we call that bookmark 3. You see all the modification up through here, and I'll do this bit quickly for the sake of time. And then we're coming back into left main, so we've got a bookmark around here. So you can do and do it here, it's a bit nicer. So you can get an automated measurement here. So it looks around sort of just over 4 to 4.5 in the left main. And then if you come distally, and you on the AVVIGO system, you can actually take the traces off, which makes it easier to the eye, because having all those colors and traces can be quite disruptive if you're trying to focus on a specific thing. And then if we go distally, we can put it back on. And actually, it's probably a 3.5. And if you just do a line measure, so I think from that, you're looking at sort of the 3.5 as your distal reference for what your stent diameter is going to be. And then on the AVVIGO, if you go to the between brackets function, it gives you a length between your two landing zones. So you can look at the length of your stent platform that you're going to pick. And we get roughly around 32, 33 millimeters between those two zones that look like they would be less than 50% plaque and quite nice to land in.
Okay, I think we've got enough information. Let's see what did they decide to do in London. If we can go back to the main screen, thank you.
It's very disrupted, this, isn't it?
They did it again, this inchworm technique.
Don't even you're bad. I think that's origami.
Okay, there it goes.
So that's too far, obviously. I just want to measure it. So about there. I can even
Up the os.
Do you think back a smidgen, or it's not?
I think.
You don't have to nail.
That's at 8.
Yeah, that's fine. Okay. 4, 5.
4, 5, 8. Yeah, that's nominal.
Yeah, fine. And we'll take some in.
Where we are now is probably more 4 as well.
Yeah, but I think it looks okay. Fine. Okay, approximately looks.
I like the new pullback speed.
It's 16.
Fine. Don't go crazy. That's probably where
very
we were
good.
there, isn't it?
Yeah, much better.
I know.
All right, well, give us numbers then. Obviously,
Okay.
emotionally, we feel better. So let's go to apicaudal, aleocaudal as well, please.
Thanks, mate.
Take a picky.
Yes. Now it's in the distal edge.
And the MSA in that is not, it's obviously it's a smaller vessel, it's after the bifurcation.
There is still an important part that we need to analyze together, and Vani will shortly guide us through the assessment of the quality of the stent implantation, which is an integral part of this IVUS 1 to 3 protocol. But before going there to Vani, there are still a couple of points to be discussed with my panelists. The first one is about DCB, drug-coated balloon. After this extent of plaque modification, angiographically does already not look so good, but if you do IVUS, it looks even worse. How are you comfortable in doing DCB in this distal marginal branch? Are there data? Is there experience here around the table?
The short answer is I wouldn't use drug-coated balloon angioplasty in this type of setting. I don't think there are good data to support that approach. I mean, we're open to new data. Sometimes we learn from observational data. We can't always wait for a definitive randomized control trial. But I think in general, in these type of lesions, we would need more data before we could comfortably recommend this as a standard approach for our patients. I think we're some way off that, in my opinion.
Of course, the downside is that we do full metal jacket there and keep standing from top to 2. And that's something we have to keep into consideration. Any divergent opinion here? Is there anyone in the room who would use drug-coated balloon in this setting, or does use drug-coated balloon in this setting? I don't know if anyone in the room can raise hands.
I mean, where we do have some experience is in CTOs, actually. So a lesser degree of calcification CTO, we know some of the issues there. If you implant a stent straight away, it's hard to appreciate the full size of the vessel. So sometimes we like to do an angioplasty-only strategy, maybe with drug-coated balloon, and then bring the patient back at a couple of months to see if additional stenting is required. But with this degree of calcification and disruption, I wouldn't.
And in terms of drug-eluting stent platform, any preference in calcified lesion?
Well, something that is important is the radial force in calcified lesion, but to me what is more important is that you have an adequate lesion preparation and that you check with IVUS, with imaging in general. So this step, the intermediate step, that is the one after lesion preparation, understanding that you have fracture, that the compliance of your vessel is modified, is increased, that's the crucial step to have a good stent expansion and to avoid under expansion. That is actually the most important independent predictor of stent thrombosis and restenosis. So to me, this immediate step, checking your preparation, and if it's necessary, doing additional preparation, that's the real most important part to avoid under expansion.
Yes.
Yeah, so we have a comment of one colleague about the DCB discussion that we had just had. Our colleague called Grigoris, he's saying very calcified and with areas of recoil already with DCB, so DCB may not be a good choice. So I think what probably the idea here is, what is a good result? Is this a good result for DCB? So when you're going to use DCB, you have to have the moment to put the DCB, you have to have a good result by angiography. I don't think you can say that you have a good angiographic result at the end of all the preparation they did with all the disruption, etc., just to treat it with DCB. Another thing is maybe the distal lesion, no? Because there was a distal lesion in a small vessel in the marginal. There's another option, and then in a small vessel there's a little bit more of evidence, but I don't think that treating such a calcified vessel like this is still any evidence about the use of DCBs here.
Let's go back to Vani, the last I was reading.
Yeah, so if you... Oh. Amazing. I didn't even have to say it. Thank you. So just on the DCB thing, I think the rationale is probably because it's such a small vessel distally, and there's probably a concern that putting more stents in, as you said, like a metal jacket, will risk downstream stent failure. The vessel actually does grow a little bit, not very distally, but within the mid part of the OM. So here you see the distal stent edge. And there is a bit of chalk between 6 and 9 o'clock of calcium, so there's some dropout. But if you keep going, you do see here then a small dissection here. If you come back through the stent, the minimal areas at the very distal end of the stent are above 8, which is very good overall in terms of we're looking for more than 5.5, 6. And as you come up, you see the areas get bigger, so that the yellow area marker, and we scroll through the stented segment, you kind of have some eccentricity to stent expansion. That's okay when you've got lots of calcium, because chasing concentric expansion causes perforation. So this is concentric stent expansion. You see that the stent's nicely up, it's opposed, and it's round. But as you come through other segments, you'll appreciate areas where here you've kind of got a good length, but the width is lower, and that's because you've got calcium abutting the two sides, so you've got eccentric stent expansion. What's actually important is the area, which we've got at 8.5, which is fine. And then as you come back into left main, you have a much bigger area, so you've got sort of 13 millimeters squared plus in the left main. So if we're looking at the 1, 2, 3, we're looking at dissections on the edges, we're looking at geographic miss. I think this was a difficult lesion because it was vessel because it was diffusely diseased, so there was never a perfect landing zone, but I think the stent is well landed. And there is a bit of a dissection distally, but I think if there's TIMI3 flow and they've decided not to chase that with multiple stents, it's reasonable to leave it. And then you've got a really good area in the left main. You've got good apposition around the nodules, which is reasonable even though some of the stent expansion is eccentric, and you've got good areas throughout, so the risk of stent failure is low with areas of more than 8.5 millimeters squared.
I think that is quite difficult to get a perfectly rounded shape result in this kind of lesion setting, so we will have to live with some degree of eccentricity all the way through the stented segment. All right, I think it's time for some key learning at the end of the session. If we can get the slide back. There we go. So this is what I captured from this session. You might agree or disagree. At least that's what I learned. IVUS guidance of complex PCI has never been so user-friendly. Of course, we had Vani here that made even more user-friendly, thanks to the improved AI algorithm. Optimal PCI result in heavily calcified stenosis is warranted when combining experience, because this is something we cannot forget, with superior knowledge of the available tools and techniques. And you have seen how many tools and techniques the team in London have used. And finally, tailoring drug-eluting devices in calcified lesion might help simplifying the procedure, which is already complex by itself, without compromising on the clinical outcomes. And I take the point from Robert that we need to produce more data, but for the time being, perhaps we can start thinking of this hybrid approach with drug-eluting stent and drug-eluting balloons in the setting of calcified lesion. I think with this, I thank you very much, and I wish you good PCR continuation.